My name is Barbara Gorgoni, and I work in the research office at the University of Aberdeen. And we host these Cafe Meds, where we bring together researchers and clinicians to discuss a specific topic. So the format for the event is that our two speakers are going to give a brief overview and introduction to the topic. We'll have a short break, and then we'll take questions from the audience. Okay, so tonight is a great pleasure to welcome Professor Neil Vargesson, Chair in Developmental Biology of the University of Aberdeen, and Dr. Alastair Lawrie, Consultant Hematologist at NHS Grampian. I'm going to hand over to Neil now. Thank you.
Thank you, Barbara. And it's good to see you all here, so thank you very much. So I am Neil Vargesson. I am a developmental biologist by training, so I like to work out how you go from a single cell to a fully formed organism with one head, two arms, and two legs, and why it goes wrong sometimes. And I'm going to talk about the history of thalidomide, why is it famous, what did it do, what do we think it does now, and then I'll pass over to Alastair to talk about its current clinical uses, and then I will come back and talk about some of the challenges. So for those of you that don't know, thalidomide is now used around the world, probably in higher quantities than it was in the 1950s and 60s, and it's a very, very effective clinical drug for lots of different treatments. But it's got a very dark history, as thalidomide. It's a drug that was created in the 1950s as a sedative. It was supposed to be a non-addictive sedative. And up until 1957, 58, most sedatives were highly addictive, and if you overdosed, you died. Thalidomide was created to be non-addictive and to be a very effective sedative, and it was a very effective sedative. It's a very effective sleeping pill, and it was found to be very effective at preventing morning sickness and other conditions. We know that was released in 1957, and in the UK it was released in 1958, and it was known as Distaval. And if you would like to see what a packet of Distaval looked like, I've got some pictures of one here, which I used to own, but I gave it away to the Thalidomide Society, and I'll explain that later. And the problem with thalidomide in those days was we don't know what the testing was done, because the testing for drugs in those days was very different to testing today. It probably wasn't tested in animals as correctly as it should have been in those days. But famously, what the drug did was it caused birth differences or damage to babies being born to mums that took that drug to treat morning sickness. And depending on which source you read, it's between 10,000 children around the world or 100,000 children in the world. I think it was probably more 100,000 or even more. And typically, the stereotypic pattern of damage for thalidomide was phocomelia, which is where your long arms, or the bones in your arm are shortened or missing. So you either have a very, very short arm and your fingers are coming out of your shoulder blade, or you have variations of that. But it didn't just affect the arms. It could affect the legs. It could affect the ears, the eyes, the face, the teeth, internal organs, the genitalia, the cardiovascular system. In fact, almost any system was potentially damaged by this drug. No two thalidomide survivors look alike. They all have slight variations. That's because it was depending on the timing of exposure that caused the damage patterns. So, November 1961, the drug was finally withdrawn. And it took a few years to get around the world because we didn't have the internet in those days. We just had telephones. And it took a long time for the drug to finally be withdrawn. And I think the last case was 1964, or the last official case was 1964. As I say, between 10,000 and 100,000 children were born with thalidomide embryopathy. A few years later, 1965, a clinician in Israel, Jacob Sheskin, had a male patient who had severe leprosy. And he had some thalidomide on his shelf. And this patient was in agony, so he gave him some thalidomide because it's a sedative. And the story goes that after a few weeks of treatment, the leprotic lesions were gone. And this is now one of the reasons why thalidomide is used around the world to treat complications of leprosy. But it's also used to treat other conditions. And since 1961, we now know the drug has got many, many different actions on the body. It isn't just an anti-inflammatory, so that stops your inflammatory system, so that's why it's effective against leprosy, but it also affects blood vessels. It stops them forming, it kills them. So that's why it's used to treat some cancers, or it's in trial to treat some cancers. It has effects on the immune system and on the nervous system. This is one drug with all those different effects. Quite incredible. So how did it do what it did? How did it cause this damage to these babies? And this is something I'm very OCD about and get OCD about. And I've spent the last 20 years looking at. And in a nutshell, we don't 100% know, but we're much closer than we were 20 years ago. My group has looked at the drug's actions, and what we did, we tried to dissect the drug out. So which of those actions I just told you about, the action on blood vessels, the action on the nerves, the action on the inflammatory system, which of those actions can cause the damage to the embryo, or is it all of them? And it turns out if you work with a pharmacologist, like I do in the US, and you collaborate with them, what that means is they do the work and you get the credit. It means that he was able to dissect out the different actions of the drug for me, and then I could put them onto chicken embryos and ask which of those actions caused the problems. And it turns out, of all those different actions, the only one that causes damage to embryos is the ability to destroy blood vessels. If you use versions that affect the inflammatory system or the immune system or the nervous system, the embryos are completely fine and normal. They don't have any problems at all. But the ones that affect the vessels have very, very severe limb damage and other problems. And if you vary the timing of exposure, you also vary the type of damage. And this is very important because thalidomide is believed to have worked in a very, very short time-sensitive window in humans, between day 35 and day 52. And that's when it was thought to cause the damage to the limbs and to the internal organs. So by the fact that we vary, so obviously earlier in that time window, the more damage you'd get, and later you'd get less damage. So this was very important for us because we were showing that blood vessels were affected, and we could also show it was acting in a time-sensitive manner. Now, I'm a bit psychic, so I can hear some of you thinking, why did it only affect a few blood vessels then, in the limbs and other tissues? Why didn't it affect every single blood vessel in the body? Very good question. It took us about 10 years to work it out, and I'm going to tell you the answer in 5 seconds. It's due to the maturity of the blood vessels. It only affects newly forming blood vessels. If you've got mature blood vessels, they've got smooth muscle over them, and that protects them, and that allows blood pressure to get your blood around the body. It turns out that thalidomide only affects the newly forming blood vessels. And so in an early embryo, the damage relates to the state of the embryo's blood vessels. So if you've got early in development, all the blood vessels are undergoing angiogenesis, the formation of new vessels, you'll destroy those blood vessels. You'll have no embryo. Later in development, only a few tissues will have new blood vessels, therefore you limit the damage. So that's how it works. It works by, depending on the time point of development and the state of your blood vessels, if it's quite late in that time-sensitive window, you might only get digit damage because the vessels in the rest of the arm have got smooth muscle. Now, there are molecular targets for thalidomide. Perhaps the most famous is cereblon. Cereblon is a molecule that's called a ubiquitin ligase. And what a ubiquitin ligase does is it targets other molecules that are no longer required in development to be removed. Have you ever wondered about this? How do molecules get rid of when you don't need them anymore? You get something like cereblon, a ubiquitin ligase. It gets rid of them. So cereblon and thalidomide bind to each other, and they've been shown to bind other molecules and destroy them. And some of them are important for limb development and embryo development. But just how that interaction, cereblon-thalidomide, causes the damage has never been shown. But would it surprise you to know that work from my group and others have now shown that cereblon and some of these other molecules are expressed in blood vessels? And so we can now square that circle and say, actually, thalidomide is binding these molecules in blood vessels. The blood vessels are destroyed. This causes cells in the limbs particularly, but in other tissues as well, to not be able to divide because there's no food and nutrients. You get cell death, so the cells then die back, the tissue dies off, and then you get your tissue damage. And then, to make things worse, nerves and muscles, which go into tissues after they've formed, then go into this tissue to try and go to the correct places, but they can't because the tissue is no longer there or it's not properly formed. And you end up with a very, very severe birth difference. And depending on the timing of that exposure, depends on the amount of damage that you get. Now, it's very interesting because in each of your long bones in your arm, you have a different number of arteries that supply it. So depending on which textbook you read, the humerus has 2 arteries supplying it, the radius has 1, and the ulna has 3 or 4. And what's interesting, in a chicken embryo, we can identify those vessels, and you can target them. And it turns out that the ulna is the most difficult bone to get rid of because it's got 3 or 4 arterial connections, whereas the radius has 1 and the humerus has 2. And the most sensitive long bone in the body, in the arm, is radius, followed by the humerus, followed by the ulna. And so we think that when it comes to thalidomide, particularly in limbs, when this drug was exposed, depending on the timing of exposure, to get rid of the ulna, you would need to get rid of 4 arteries. If you're going to get rid of 4 arteries, you're probably getting rid of a lot more arteries in the body, so you're going to end up with lethality. And so we think that the radius is the most sensitive tissue because you only needed to lose 1 artery. So it's much easier to lose 1 artery than 4, right? And that might explain some of the damage patterns you see. And so this also points out to another point, which is I don't think there's ever a safe time in pregnancy that this drug could be taken. The theory was that between day 35 and 52 was when it was sensitive, and before that and after that, there was no effect. I think before that, it would cause miscarriage because vessels would be destroyed, and I think after that, you would have internal organ problems. So that's in a nutshell, how it does what it does, or how we think that's what it does. And now, of course, it's used around the world to treat leprosy and other conditions, which Alastair will talk about in a second. And the one thing that I'm interested in now is irrespective of the molecular targets that this drug affects, we know that actions on the blood vessels are causing the damage. It doesn't matter if the targets are involved. So can you make forms of the drug that don't cause limb or birth differences but still have the clinical benefits? And so some of the stuff that we've been doing recently is re-engineering thalidomide to have the good bits, if you like, so the bits that affect the inflammatory system and the immune system, but they don't affect the blood vessels. And we identified some, and we're now doing work to show that these versions that don't affect blood vessels are safe, don't cause birth differences, and are clinically relevant. And my goal in about 10 or 15 years' time is to try and put thalidomide in the bin and just have these new versions so that you don't get any more children being born with birth differences. Because unfortunately, in Brazil, to this day, thalidomide is used to treat leprosy, and it's endemic. And unfortunately, there's a new generation of children being born with thalidomide embryopathy because the medicine is shared amongst people when they don't understand that this medicine is not safe. And so the goal in 10 years' time for me is to be able to get rid of thalidomide, put this new version on the market, and hopefully stop that happening in the future. That's the plan, anyway. So I'll hand over to Alastair now, who's going to talk about his current clinical benefits, and then at the end, I'll come back and talk about a few more challenges. Thank you.
Thanks very much, Neil. That was really, really interesting. Thanks, everyone, for coming out. My name's Lawrie. I'm a haematology consultant over the road in Aberdeen Royal Infirmary. I suppose this is the opposite end of the spectrum. I'm going to be talking tonight about my practical experience of using thalidomide and similar drugs. This is the clever end of the spectrum. I'm going to be a bit more, a bit more anecdote-based. My first exposure to thalidomide was when I was a medical student. I did my elective in a leprosy hospital in Nepal, south of Kathmandu. And I've kind of always been interested in medicine as opposed to surgery and science. I did an undergraduate science degree just along the corridor from Neil's lab here. And I got out to the leprosy hospital and found that leprosy is primarily a surgical specialty. The complications that patients experience as a result of leprosy, which are incredibly debilitating, the hospital inpatient treatment is primarily surgical, and it's fascinating. It causes extensive nerve damage, it causes extensive deformity, and much of the hospital that I was working in was basically full of patients who'd had amputations, who'd had plastic surgery, who'd had orthopedic surgery. Some of it was, fascinating but horrific. So I was a bit sort of taken aback when I found that I'd sort of come to stand in an operating theatre for 3 months. And it was brilliant experience. But then I sort of found that when I asked about this, I said, go up to that corner of the hospital, there's a bit of medicine up there. And there was a small corner where people with the medical complications of leprosy were getting treatment. And the use of thalidomide was when it first came to me then, which was the specific complication, erythema nodosum leprorum, which is a sort of immunological reaction to leprosy, is what thalidomide is used for. And the dermatologist who treated these patients said, oh, we use thalidomide. And I went, oh, I've never heard of this before. I'd obviously heard of thalidomide for all the things that Neil's talked about. And in contrast to how you hear about it in Brazil, it was locked in a safe. It was only given to male patients, and it was only given directly supervised. So if you were female and you had this complication, you had to go with standard treatment, which wasn't as good. So that was my first exposure. And then I came back and I did my junior doctor training, and I ended up rotating into hematology. And that was when I found it as a treatment for myeloma. And myeloma is one of the primary cancers that I treat. Myeloma is a blood cancer. And to this day, we still use thalidomide as one of our frontline treatments. It's currently part of our first-line approved chemotherapy combination for treating myeloma in younger patients. And when I went into hematology, it had just been introduced in a clinical trial. So myeloma, for those of you who don't know, myeloma is a type of blood cancer that rises in the bone marrow, and it causes a wide range of complications, and it can be an incredibly debilitating disease. Over the last 10 or 15 years, there's been a massive expansion in the amount of treatment that we now have. The treatment that we used back then was radically different from how we treat it now. Thalidomide was the first in a sort of the vanguard, if you like, in terms of the new targeted class of medications. And one of the things that attracted me to hematology was these new targeted therapies. So we've gone through decades. We still use standard, what we call cytotoxic chemotherapy. And these are drugs that basically it's like going out into your back garden and spraying it with Roundup. These are drugs that kill dividing cells, and they kill cancer a bit better than they kill normal cells, but you effectively are left with a multitude of side effects. So the gold standard, the holy grail in cancer treatment is finding that drug that has exquisite 100% effect on the cancer and no effect on the host cells, and thus no side effects and no risk. And in certain situations, that's actually not far off. And thalidomide was an early example of something that looked a bit like that. It was a tablet. It was taken at home. It superficially you didn't take it and explode. But actually, it was a pretty miserable drug to take. And my early recollection of patients with myeloma receiving it was that it was actually quite attritional. So we tell them you have to take this in the evening because it puts you to sleep. So that the same therapeutic effect that it was used for as a sedative was actually quite debilitating for a lot of patients. It caused terrible nerve damage in some patients, terrible neuropathy, so pins and needles, sometimes painful, terrible constipation, just switched off the bowel. When you give it alongside other myeloma treatments, it massively ramps up the risk of blood clots. So we had to give them warfarin, to minimize the risk of blood clots. And I suppose set against this, incredibly effective at treating myeloma and a tablet-based treatment. So this was a huge step forward for these patients who, up until that point, been sat in hospital getting infusional chemotherapy, parked on the ward. Now you can take this tablet and go home. But it wasn't the nicest medication to take. So you might ask, well, why are you still using it? And this is where the cynicism starts to creep in, okay? So I asked around my colleagues, as I'm giving this talk tonight about thalidomide, What can anyone remember? And the thing that stands out about when this drug first kicked in was, and I was a trainee at the time, I says, well, how does this work? How does it treat myeloma? And everyone kind of went, don't really know. It just seems to do so. And the class of medication that it falls within is still to this day labeled IMiD, immunomodulatory drug, which is really coded speak for we don't really know. And there's, the data that have emerged, and it's some really quite exquisite, elegant science about how this mechanism of action works, always seems to have a caveat, always seems to have a sort of counterpoint, which says, well, if that's true, what about that? So obviously the next step in the process was, well, can we make a better one? Can we make it work more effectively with fewer side effects? So the main drug that we actually use most of the time is its little brother. So we have thalidomide. And then about 5 or 10 years later, another drug came along called lenalidomide. And lenalidomide is still front and center to this day for treating myeloma. And lenalidomide is a more effective drug. It has a higher chance of inducing responses. It has fewer side effects, and it can be taken more crucially for a long, long period of time. It's quite well tolerated. It's our standard first-line treatment for older patients. So the key thing about this is why do we use thalidomide to this day? Well, thalidomide is cheap because thalidomide has been around for a long time, and thalidomide has now been replaced by newer versions, which are not cheap and are extremely expensive. So one of the things that we limited ourselves with in using thalidomide is that you can't give thalidomide for long periods of time. What we tend to find is you get cumulative side effects. So the patients who tolerated it started to get nerve damage. Even if they weren't at the start, they'd start to get quite significant nerve damage, quite significant constipation, and eventually they'd all get fed up and say, I can't take this anymore. And the quality of life that these patients experienced was not brilliant. So the aim was to try and develop these new treatments. Now, the problem with taking lenalidomide for long periods of time is that not only does that carry risk of side effects, it's financially extremely toxic. So lenalidomide and the class of medications that it falls within currently occupies I think it's currently our second biggest spend within the haematology department. So last year we spent between £1 and £2 million treating patients in NHS Grampian with these class of medications, okay? Which is pretty, that's just for Grampian, okay? So if you scale that up across the United Kingdom, you see what sort of money we're talking here. The next, I suppose the other aspect of using these medications is, as Neil has alluded to, that they came with this checker past in terms of the risk of causing birth defects. Now, the practical reality of that is that the patient groups that I am treating, for the most part, so myeloma, it has an average age of diagnosis of 73. And for the most part, these are patients who have, firstly, symptom burden from their illness. They have other health conditions, and they're older. Okay, so the risk of birth defects in this patient group, on average, is a little bit less than the patients being treated for leprosy. They tend to be older. Okay, and we approach them all slightly differently based on their characteristics. Okay, and this is one of the key things because we have to employ a pregnancy prevention program. And basically, in order to give out any of this medication, we have to show that we have done everything we can to prevent a pregnancy, an unwanted pregnancy. So, for example, if you have a woman who is deemed of childbearing potential, and that's any woman who is still naturally having periods, then they have to demonstrate that they have a negative pregnancy test within 7 days of any prescription, and it can only be issued every few weeks. Okay. If you're a man of any age, because there is a theoretical risk of thalidomide or lenalidomide or any of its derivatives, because we make the assumption that all the derivative drugs have the same potential risk, then any man has to basically say that they are either going to use condoms, or they're going to be sexually abstinent, or they're going to have a partner who has double contraception. So you're often having this conversation with a little guy in his 80s who's falling over with severe pain from myeloma. You have to have that conversation every time you dispense the drugs. And I have to say, it's a conversation that patients take remarkably well. Maybe I'm just downplaying it. Maybe I'm kind of going, well, just skip over that bit, sign it there. Or I don't know, I'm not intentionally doing that. But I'm always surprised that patients don't get, I don't know, more upset or twisted up by it. But to give you an idea, a patient of mine who has had terrible, terrible problems, newly diagnosed chap, who ended up going to Roxburgh purely for symptom control. Who's actually doing quite well from the myeloma perspective, who we had initiated on one of these medications a couple of months ago. I was told I had to go to Roxburgh House to tell him to reinforce the need for contraception, to use a condom. This guy can barely walk unassisted because of the need for intense pain control. So the point I'm trying to make is that even to this day, we are still employing a fairly heavy-duty pregnancy prevention system to try and mitigate against the risks involved here. I suppose the last thing I'm going to say is that because you have a drug that we don't really know how it works, let's be honest, we don't really know how it works, and it does wonderful things in myeloma, the natural thing to do is to give it a whirl in lots of other things. And that's what's happened, particularly in hematology. And it's still not really clear to me why it works so well in myeloma, but not quite as well in lots of other conditions. But we use these drugs for a number of other conditions. We use it for treating a condition called angiodysplasia, which is where you get abnormal blood vessel formation in the bowel, and you get bleeding. And it's not really understood why that happens. And we've tried thalidomide for kind of obvious reasons. It switches off blood vessel production. Doesn't really work. Patients get miserable on the thalidomide. So we haven't had a great deal of success with that. We use lenalidomide as a slightly more effective treatment for a wider range of conditions. We use it for treating certain lymphomas, and we use it for treating a condition called myelodysplastic syndrome, and it seems to be extremely effective in those conditions as well. Quite why, I don't know. And really, that's about it. So I'll maybe pass back over to Neil now just to finish off, but I'm happy to answer any questions afterwards.
Thanks, Alastair. That was great. Following on from that, so there's a few challenges, right? So, in fact, I take it everyone in the audience has heard of COVID-19. Yeah. So thalidomide was in clinical trials. Well, it's still in clinical trials to treat the severe lung complications with COVID-19. So thalidomide undergoes a renaissance every couple of years. It's found to do something else and treat something else, and we don't know how it does it. So how can it treat myeloma? How can it treat these, COVID-19, and how can it have all these different actions? Is it acting through one or two molecules, or is it acting through a pleiotropy? Is it acting through lots? I suspect it's got multiple different ways of doing things. But it goes back to it's got more uses, therefore it's going to be used around the world more often. So we need to understand how it works. Really do. And I think the COVID-19 crisis showed us that nothing's impossible. We came up with vaccines very quickly that worked. And if we put our minds to thalidomide, we can find out how it works and then make a safe form of the drug that eradicates all these different side effects. And this leads on to another challenge, which is linked to that, is how, we know that there are genetic causes of limb malformations, but we don't know how the loss of the gene actually causes the malformation. Is it through loss of cells? Is it through loss of blood vessels? Is it through something else? And I think the thalidomide thing has taught us that just because you find a few genes doesn't actually mean you can join the dots up and say that's how it causes a problem. So if you understand how thalidomide works, maybe you can then use that to understand how genetic causes of disease come about as well. And finally, how many people did it really affect? In the 1950s and 60s, the records were not kept very well. I mean, I've already shown you that the UK Distal packet of thalidomide was just given out willy-nilly to people. So we'll never know how many people were really affected. So how can we help people that think they're affected, and how can we resolve that? And there are people all over the world, US, Canada, Ireland, Malta, Spain, Italy, Australia, that believe they're affected. And it comes down to hopefully trying to persuade governments to set up committees that look at those people's damage patterns, look at the available science, look at what the drug actually does to embryos as opposed to what we thought it did in the 1950s and 60s, and see if we can help those people out. And those, to me, are the three biggest challenges. Can you make the drug safe? Can we help it? Can we use that to help understand how genetic problems come about? And can we actually help people that believe they're affected? And either give them an answer they might not like it wasn't thalidomide, but hopefully set their minds at rest. So thank you.